Hi guys, I'm Dr. Sandeep, your surgery guy. So, welcome to another session of Surgical Saturday with Dr. Sandeep. Today's session is on thyroid. I've got a lot of messages on my personal DM on my Instagram as well as on our PW channel. There's plenty of messages that came after the first session, giving a lot of warm and affectionate feedbacks. Thank you for that first in the first instances. Apart from that, I've got a lot of suggestions because majority of you are also going to the exam, that is your NEET PG 2024 or 23 extension there. But in that context, I found that few topics or few things which are going to be extremely relevant from the exam point of view, that is going to be extremely important, right? Hi guys, good evening, good evening. So today's objective is to emphasize on those smaller concepts so that you're going to be helping in the same context. Hi guys. I just saw the chat box. Yeah, it's still recovering. I somehow got some energy to pull up a bit for today. You can see the voice is still on a heavier side. Right. Thank you for asking. So yeah. So as I was saying that these sessions as a student you can use to ask any sort of doubt or any particular problem that you feel that it is not explained well, you are not able to understand well. How well can you actually come across it? So what is the factor in which I can use this session? It is like those topics, those small concepts which you fail to understand or you're not able to get a grip of it. You can always write it down to me, send a DM, or you can comment on the YouTube channel itself, so that we pick up those small topics and then compile together as a student query and put forward you, right? So today I'll be talking about the thyroid gland. Now in the thyroid there are a lot of gray areas which we do not understand well, so I'm going to put some light on it and try to understand how better we can pull that across from here, right? So one of the major aspects that I feel as a student that you have a bit of difficulty in understanding is with the anatomical orientation itself, right? Now many a times you've been asked that what is the differentiating factors in thyroid. So in the thyroid anatomy, let's quickly go through. There's a bridge that is going to be developing, and you will have the butterfly shaped gland which is going to be developed on the either side, right? Now when you look at this, the easiest way to understand or to get through it is to label them, right? Now this is what we call it as the left lobe of the thyroid gland. The contralateral side, this is on the other side, will become the right lobe of the thyroid gland, and the bridge that is present between these two, needless to tell you, it forms the isthmus of the thyroid gland. This forms the isthmus of the thyroid gland, right? Now this thyroid gland will further be divided into a smaller section with these fibrous septas which are present, and these fibrous septas are going to divide the thyroid gland into smaller components, and each component is now referred to as a lobule. Now within this lobule you have the functional cells, right? The functional component of the thyroid gland, which is called as the follicles. So the follicles of the thyroid gland will be present inside these lobules. The follicles of the thyroid gland, the follicles of the thyroid gland will be present within these lobules, right? Now the follicles are the true secretory organelles. Follicles are the true secretory organelles. So if you're not able to see, this is the division of the lobule. This is how it has been divided into smaller subunits. These are called as lobules. So lobe is divided into lobules, and the lobules will harbor the follicles. Lobules will harbor the follicles, right? Now this each unit or functional unit is what we call it as the follicles. As all of you know, the follicles are responsible for secretion of T3 and T4 hormone. Follicles are responsible for secretion of T3 and T4 hormone, right? Now around these follicles you have the specialized cells which are going to be present, and these specialized cells around the follicles are what we call it as the parafollicular C cells. These are what we call it as the parafollicular C cells, right? These are what we call it as the parafollicular C cells, right? Now, as the name itself suggests, they are parafollicular, right? So parafollicular is around the follicles, and they are called as C cells because they secrete calcitonin, right? What do they produce? They produce calcitonin, which is going to help in calcium metabolism, right? Now, this is the basic division that you need to understand with respect to the thyroid gland, right? Now, sorry. Now, when you look at the objective, you will understand that each of them will have a very, very precise component to be understood, right? For example, if I say between the lobes, remember the right lobe of the thyroid gland will always be larger when compared to left lobe because of its developmental status, right? Second thing that you will notice, that they start from the C5 to T1, that is the extent of the thyroid gland. That means the superior pole will be seen at C5 level and the inferior pole will be seen at the T1 level. Then we talk about the isthmus of the thyroid gland. The isthmus of the thyroid gland will be found between the third and the fourth tracheal rings. So here we are talking about these are the tracheal rings, not the vertebrae, right? Now, then comes, where did the follicles comes from? When we talk about the follicles of the thyroid gland, they are derived from the epithelial lining. They are derived from the epithelial lining of the thyroglossal duct. So they are derivative of the epithelial lining. They are derived from the epithelial lining. They are derived from the epithelial lining of the thyroglossal duct. So the question is, where does C cells derive from? C cells are the derivatives of lateral analgae, right? They are the derivatives of the lateral analgae. They are the derivatives of the lateral analgae. Okay? So this comprises together this comprises together to form the basic objective of the thyroid gland, right? Now, when we talk about the follicles per se, now you need to understand that when we talk about the follicles, I can divide them into two components. One, we have the functional follicles. Another one is what we call it as the dormant follicles. Another one is what we call it as the dormant follicles. So you have the functional follicles and you have the dormant follicles. Now, how do you differentiate, right? Now, when you look at this, in the functional follicles, this is the follicles that are present, right? So these are the follicles that are present. How to differentiate between functional and a dormant follicle? In a functional follicle, you will see a wider epithelial component or the cells which are present. So these are lined by cuboidal epithelial cells. Whereas the dormant follicles, you will see they are lined by the tall, slender columnar epithelium. They are lined by the tall, slender columnar epithelial cells. They are lined by the tall, slender columnar epithelium. They are lined by the tall, slender columnar epithelial cells, right? So the differentiation of the functional and the dormant comes from the status of the epithelium. If it is cuboidal epithelium, then it is functional. If it is columnar epithelium, then it is considered to be as a dormant follicle. It is considered to be a dormant follicle. Now, when we say functional, what function are we truly speaking about? So in the functional status, we're talking about the T3 and T4 production. So that is a thyroid hormone, that is T3, T4 hormones production is what, that is triiodo and the quadriiodo components that are going to be present, which is going to be a T3, T4 hormone production. Now, how is the T3, T4 hormone basically produced? So what is going to happen is the iodine that is going to be absorbed from the gut is now going to move into the follicular cell. Now imagine that this is a functional follicular cell. This is a functional follicular cell, and on the surface of this functional follicular cell you have this ion gated channel, right? Now this ion gated channel is what we call it as the sodium iodine symporter. So it will take the sodium and iodine, right? So with every one sodium that goes in, the iodine will also go inside the follicular cell. So once the iodine reaches inside the follicular cell, what is going to happen to the iodine? The ionic iodine is useless for the body, right? It is not going to help because it is stable. So we have to convert this into a free radical iodine, and this conversion into the free radical iodine is done with the help of an enzyme that is called as the thyroperoxidase enzyme. That is a thyroperoxidase enzyme. Now this free radical iodine is highly unstable, so it is going to combine with tyrosine, which is readily available inside the follicles, and this will give rise to an organic compound, and this organic compound will exist in two forms, that is dimers. One is your monoiodoform, another one is the diiodoform, right? Now this organic compound will undergo something called as the coupling reaction. This will undergo something called as the coupling reaction. In the coupling reaction, you will notice the monoiodoform will combine with the diiodoform. So mono represents 1 and di represents 2. So together they form T3. In the same manner, the diiodoform will combine with the diiodoform. Again, di indicates 2, that is 2. 2 plus 2 is 4, so it will form T4 component. It will form a T4 component, right? So that is how the T3, T4 are formed inside the follicular cell, right? Now, once the T3, T4 are formed, they are not going to jump across, right? You need to understand within the follicular cell when the T3, T4 are formed. So let's say this is the follicular cell, and imagine that there are multiple components of T3, T4 are formed. So I'll give them a color code. Let's say the T3, T4 are the blue ones, right? So these are the T3, T4 hormones that are produced. So when you see the T3, T4 are produced within the follicular cell, 99% of them will be attached to a protein molecule, right? 99% of them will be associated with a protein molecule that indicates what it is going to be in a bound state. It is going to be in a bound state. So you notice that this is in a bound state. This is in a bound state, and you can hardly identify a hormone which is in a free state. Now remember, the bound state is useless for the body. It is a free state that is readily available for the body. When I say it is bound to what? It is bound to 3 standard proteins that can be remembered as GAP. G stands for globulin, A stands for albumin, and P stands for prealbumin, right? Out of all this, remember, more than 90% of the thyroid hormone is bound to the globulin, and rest is to the albumin and prealbumin, and that is why the alternate name of this globulin is also called as thyroid bound globulin. It is called as TBG. Now it is only this free state, it is around in the 1%, which is freely available. It's a free state which is going to be available for the body, right? Now in that also you see it will have two components that are produced. One is T3 and T4. Remember, out of T3 and T4, I hope everybody knows that T3 is the active form and T4 is the passive form. So whenever the body requires, it is the T3 that is going to compensate for the need for the body. That is why, remember, T4 is produced far more in larger quantity when compared to T3. It is going to be more than T3, right? So you will notice once the T3, T4 is formed, and whenever the body requires excessive amount of T3, right, rather than looking for anywhere else. The body, it's a beautiful mechanism that body has developed, that whenever the demand for T3 is going to increase, rather than going and reproducing the T3, the T4 will now be converted into T4 will now be converted into T3, and this conversion is what we call it as the peripheral conversion. This is what we call it as the peripheral conversion, and the enzyme responsible for peripheral conversion is 5' deiodinase. It is called as the 5' deiodinase. And remember the sites where they do or they cause the peripheral conversion. The sites of the peripheral conversion, number one, it is going to be your skeletal muscles. Number one, it is going to be your skeletal muscles. It is your skeletal muscle. Number two, in liver, a little bit of that in pancreas, and a bit of it in pituitary gland as well. A bit of it in pituitary gland as well, right? Sorry guys. Alright guys, right. So this is with respect to the hormone production. Now, who determines that this hormone will be released? Now, it is with the help of a common axis that is called as the hypothalamus, the pituitary, and the thyroid axis, right? So let's create that axis. The high command is the hypothalamus. Let's say this happens to be the hypothalamus that we have. The hypothalamus is going to control the pituitary gland. This happens to be the pituitary gland. The pituitary gland will be controlling the thyroid in this particular one, right? So this is your thyroid gland, right? Specifically talking within thyroid gland, just for the sake of understanding, we'll create these are follicles, right? So how does this basically work out? Is hypothalamus is going to produce a hormone that is called as the TRH, that is your thyrotropin regulating hormone. It is your thyrotropin regulating hormone. Now, this thyrotropin regulating hormone will stimulate the pituitary gland, and the pituitary gland will produce a hormone that is called as TSH, that is your thyroid stimulating hormone. This is what we call it as the thyroid stimulating. This is your thyroid stimulating hormone. Now, this thyroid stimulating hormone that is present, or the TSH hormone, has two basic functions, right? What are the two functions is, number one, it is responsible for follicular stimulation. It is responsible for follicular stimulation, and second, it is going to act as a growth factor. So whenever the TSH is in excess form, it is going to promote the growth. So what is going to happen is, this TSH which is produced is now going to go and stimulate the thyroid follicles. Now, once they are stimulating the thyroid follicles, stimulation of thyroid follicles will cause a release of T3 and T4 hormone, right? So once the T3, T4 hormone are released, the concentration of T3, T4 in the blood will start to increase. So once the concentration of T3, T4 will start to increase, it will send a negative feedback. It will send a negative feedback to the hypothalamus. It will send a negative feedback it will send a negative feedback to that of hypothalamus. It will send a negative feedback to that of hypothalamus that you have enough quantity of T3, T4. Kindly stop producing TRH so that the TSH will also decrease and the follicular stimulation can come into a halt. So this whole cycle runs, but again, the whole cycle will only continue to run if there is normal iodine supply. This will run normally if there is a normal iodine supply is maintained. So what is the daily iodine requirement? Remember, the daily iodine requirement is going to be 0.1 to 0.15 milligrams per day. This 0.1 to 0.15 milligrams per day is your daily iodine requirement so that the patient can remain euthyroid or they can have enough amount of thyroid hormone that is being produced. Okay. Now this whole cycle is very important for us to understand because the whole concept of it is going to be in a cyclical form in this manner, right? Now it continues to happen. It will only happen if this axis remains intact, right? Now what is this negative feedback? Just for you to understand, the negative feedback is like a seesaw, right? You create this as a seesaw. We talk about the negative feedback in the understanding like a seesaw, right? Now let's say this is the seesaw's head that is present, right? On one hand, I will say there is T3, T4 concentration. On the other hand, we'll talk about the hypothalamus, right? Now, how it works out is whenever the T3, T4 production will increase, the hypothalamus has to underperform, right? The hypothalamus stimulation will decrease, right? In simple way, if I make the seesaw, this is what the negative feedback is. You will see the tilt will be like this. Whenever the T3, T4 is on higher status, the hypothalamus will be on a lower status. On the contrary, whenever the T3, T4 decreases, whenever the T3, T4 decreases, or if there's a decline of T3, T4, if there's a decline of T3, T4, the hypothalamus will get stimulated. It's like a seesaw, it's balancing, right? So you need to understand, just for the sake of understanding, I'll draw the neutral axis. Okay. So you will understand that whenever T3, T4 increases, the hypothalamus stimulation has to come down. Obviously, no. If the hypothalamus stimulation does not come down, TRH will continue to produce, TSH will continue to produce, more and more T3, T4 will be produced. Patient will go into hyperthyroid status, right? In order to prevent that, you have this negative feedback mechanism. See, the word negative sounds very bad, but originally what it means is, it means an opposite feedback. Negative feedback is basically an opposite feedback mechanism. It is an opposite feedback mechanism. Clear? Okay. So this is what you need to understand with respect to the stimulatory effect. Now, another very important question, as we are addressing whys for every particular question that we have, who determines the negative feedback? So the negative feedback जो है, the negative feedback, who is going to determine it? Is it the T3's concentration or is it the T4's concentration? Who determines the negative feedback? Who determines the negative feedback? Now let's say all those people who are thinking that the T3 will determine the negative feedback, right? Now I will create a small pool. This is a pool of T3. Let's say this is a pool of T3. And let's say this is a pool of T4. As we all know, we have more amount of T4 when compared to T3, right? So this is a pool of T4 and that is the pool of T3. Now let's say this is the tissue. Let's say there is this block of tissue that is present which requires the thyroid hormone, right? So this is the block of tissue that requires the thyroid hormone. Now we know the active form is the T3, the T4 basically cannot do much about it, right? So what is going to happen? The tissue is going to consume the T3, right? Now, as the tissue is consuming the T3, what is going to happen? The concentration of T3 will start to come down. You will notice as the T3 is being utilized, you will notice that this T3 which is present will start to become lesser. Now, as the T3 is becoming lesser, but the tissue is hungry, tissue still needs more amount of T3. So what is going to happen? If the body was relied on the negative feedback from T3, as the T3 depletes and the demand is still high, it would have told the hypothalamus would have told the pituitary gland would have told the thyroid gland, and then the T3, T4 would have been produced, and then it has to be released. So the time taken is pretty long, right? And body or the tissue cannot wait for that long. So what happens is, immediately to compensate this, you will now notice that the T4 will now start converting into T3 to fill the T3 back. Now, as the T4 is converting into T3 in order to fill the requirement, the T4 concentration will starts to come down. Now, as the T4 depletes, it's a feedback for the hypothalamus to say that now the reserves are also going down and you need to start kicking back the cycle. So it is a decrease in T3 which stimulates the negative feedback, right? So this is a very, very beautiful and a simple concept that you need to understand, that how the negative feedbacks are playing a very, very important role. Okay, so this is all in all the entire component in terms of the negative feedback mechanism and the stimulatory effects. Yeah. Now, another very important concept is, how is the thyroid swelling being developed, right? Just for the sake of understanding, let's simply talk about the thyroid swellings for a minute. So when we talk about the thyroid swelling, I would like to divide the thyroid swellings into two categories. One is a generalized thyroid swelling, which is going to be diffuse. So I can divide them into diffuse and localized thyroid swellings. We can divide them into diffuse thyroid swellings and localized thyroid swellings. So you have the diffuse and we have the localized thyroid swellings, right? Sorry, we have the diffuse and the localized thyroid swellings, right? What do you mean by diffuse thyroid swelling? In a diffuse thyroid swelling, you will notice that the entire gland is going to be enlarged. Now let's say if this is the, let's say if this happens to be the normal size of a thyroid swelling or thyroid gland. Okay, I don't know why it is misbehaving. Such behavior is not acceptable. Oh wait. Okay, so it collapsed. It was not able to take the load of these many concepts. So sorry. The only thing is, I hope that it does not go away. Okay, it didn't go away, right? Sometimes when it collapses, no, even the file goes off. So much pain. Okay. Now, oh, it has now started to spill magic. Now, let's say this is the normal size of the thyroid gland, right? Now, in a diffuse thyroid swelling, we say the entire gland is going to get enlarged, right? The whole gland uniformly in either lobes has become enlarged, and this diffuse enlargement is also commonly referred to as goiter. Right? So this diffuse enlargement of the thyroid gland is what we refer to as goiter. In a localized thyroid swelling, we have two varieties. One, we call it as the solitary thyroid swelling. One is the solitary, another one is a dominant thyroid swelling. Now, what is this solitary and what is this dominant is? If you take this as the representation of the thyroid gland, you take this as the representation of the thyroid gland, and then from one of the lobes, in any one of the lobes, you see there is a isolated nodule that is going to present. This is what we call it as solitary thyroid nodule like presentation. On the other hand, when we say dominant, in the dominant status, it's actually a multinodular status, but you will see that in one nodule which we far more larger in size when compared to the other nodules which are present, which are smaller. So dominant will have multiple nodular swellings, but one outsizes the rest. In fact, more than 70% of your localized thyroid swellings are solitary. Only 30% of them are usually dominant, right? So this is a basic objective. So for a localized swelling, we do not have a specific answer as in how why it is happening. But when it comes down to the goitrous presentation, we do have an answer that how usually the goiters are formed. Now, let's understand the magic behind the goiter. Now, I don't want to go into greater details about the causes, right? Uh, what is a primary iodine deficiency? The patient's intake of iodine is reducing. That means the daily requirement was 0.1 to 0.15 milligrams a day, and the patient is not able to take that much amount of quantity. Usually we see in endemic status, right? So endemic goiters are one of the most common causes where you have deficiency of iodine intake, right? What are the reasons? Usually you will see these goiter like presentations or goiters are more prevalent in the areas where the soil itself have deficiency of iodine. Example like hilly areas, as the downstream of the water flows, it washes away all the minerals, right? So in the same context, it just takes it away. That is in the form of the endemic goiter state. Otherwise, anyone who is not taking a adequate amount of iodine can result in development of goiter. As simple as that. Secondary iodine deficiency is you're taking the normal quantity of the iodine, but the iodine is not being able to utilize by the follicular cells. One of the best examples are goitrogens, your Brassicaceae family members like cabbage and all. Another one is dyshormonogenesis, where the thyroperoxidase enzymes are becoming less, right? This is the deficiency of thyroperoxidase. Another reason another reason that you can see can be seen in use of certain drugs, example like amiodarons, right? So these are the basic in nutshell what results in goiter. Now my question to you is very simple. Why, okay, whatever might be cause, why is the gland enlarging in size? As simple as that. In order to understand this, we'll take a linear axis. Let's say this is the hypothalamus. This is the hypothalamus. This is the pituitary gland. This is the pituitary gland, and this is going to control the thyroid gland, right? So we had the axis pretty sorted out. We said that we have the hormone, that is a thyrotropin regulating hormone producing TSH hormone. The TSH was stimulating the thyroid follicles. The thyroid follicles were producing T3, T4. They are producing T3, T4. And when the concentration of T3, T4 was becoming adequate in the blood because of negative feedback, we would have stopped the stimulation in the hypothalamus. So this is where the negative feedback kicks in. Okay. Now we all know that this cycle would run happily if the iodine supply is maintained or it remains normal. Okay. Nothing spectacular. We have already discussed about this cycle. So you know how the follicles are being stimulated, how T3, T4 is produced, and with the help of that feedback, how hypothalamus is controlled, and then the whole cycle continues to happen. Now imagine that now we have a problem in hand, and the problem in hand is the iodine deficiency has kicked in. Right? Now, if the iodine supplied to the thyroid follicles is less, no doubt what is going to happen? T3, T4 will also reduce. Now when the T3 T4 is reducing, remember our seesaw, T3 T4 is becoming less, so what will happen to hypothalamus? Hypothalamus will increase, right? So there will be, because of negative feedback, there will be stimulation of hypothalamus. Because of stimulation of hypothalamus, the thyrotropin regulating hormone will increase. Increase in TRH will also cause increase in TSH. In the initial phases, because there's excess amount of TSH, there will be more stimulation. So T3 T4 will be produced more, or they'll be released more until the reserves are there. But after some point, what is going to happen? The reserves will deplete, right? Now what is happening is the TSH will become or remain constantly high because T3 T4 is not being adequately produced. It is like I'll give you an example. The example is like a sugar cane machine, right? You put the cane from one end, the juice will come from the other end. Now if you don't put the cane and you continue to spin the machine, would you get the juice? The answer is no. In the same way, without providing iodine, you keep giving TSH, there will be no T3 T4, right? So what is happening now? You notice that there is excess amount of TSH. Now you remember I told that TSH has two major functions. One, it is going to stimulate the thyroid follicles. Second, it acts as growth factor. Now it will only promote growth when TSH is in excess, and now we can see here that we have excess amount of TSH because the T3 T4 is less. Negative feedback is continuously happening. So more amount of TSH, that means more stimulation of thyroid follicles. Now because of excessive stimulation, it is now going to cause growth factor effect, right? As I told you, TSH in larger quantity promotes growth. So what is going to happen? It will result in development of both hypertrophy and hyperplasia of the thyroid follicles. Now under the influence of this, because of hypertrophy and hyperplasia, you will now notice the thyroid gland is going to enlarge. You'll see the thyroid gland is now enlarged tremendously, and that enlargement is because of the hypertrophy and the hyperplasia of the thyroid follicles. You see the thyroid follicles have enlarged. Now because of these enlargement of the follicles, the entire gland is going to enlarge, right? The entire gland is going to enlarge. The entire gland is going to enlarge under the influence of this hypertrophy and hyperplasia, right? And this is how the goiter is formed, right? So the diffuse, because it is completely enlarged, this is also called as the diffuse hyperplastic goiter, also referred to as the diffuse hyperplastic. Now at this particular state, if I intervene and give the iodine, or if I supplement the patient with iodine or the thyroxine hormone, it is going to revert back. It's a reversible state, right? So we also call this as a reversible status, right? So diffuse hyperplastic goiter is a reversible, or I can say it is a reverting condition, or it's a reversible state. It is a reversible, state, as simple as that. Yep. Now if you have a patient with thyroid swellings, how would you deal with them, right? Now I have couple of small video representation just for the sake of understanding. See, the time is very small, so I cannot bombard a lot of information, but I can give you few of the components here. Now first of all, when you look at this image, I'll give you a history. She is a 52-year-old female presented with the swelling in the midline of the neck, right? If you are able to identify, it's pretty great, but if I just mark it down, this is where you can see the swelling, right? So this is the swelling. Now by the look of the swelling, can you tell me, is it an isolated, or I can say, is it a localized thyroid swelling or a diffuse thyroid swelling? If you are there on the chat box, can you comment, is it a localized thyroid swelling or is it a diffuse thyroid swelling, right? By the look of it, it's a solitary swelling, right? It's a solitary swelling, so it is going to be a localized thyroid swelling. Now as we go into details, you will understand more and more that there's a very specific thing. Let me move this picture a bit up because we need it. We have to preserve the identity here. You can see, how do you know it's a thyroid swelling? It moves upwards with deglutination. Now there's something specific. You can see here, as she is going to stick her tongue out, the swelling is also going to move along with that, right? So you can see, there you go, right? So every time she sticks her tongue out, the swelling moves with the protrusion of tongue as well. Needless to tell you that this is a case of thyroglossal duct cyst, right? How do you know? Thyroglossal duct cyst is the only swelling that is going to move upwards with protrusion of tongue. At the same time, it is also going to move upwards with your degglutination. A reason, you have attended my lecture, you would know why thyroid swellings move upwards with degglutination. They move upward with degglutination because of its attachment to the pretracheal fascia with the help of Berry's ligament. No further doubts in that. Okay. Now another swelling that you can see here. Now you have to tell me what type of swelling you can see here is. Is it a localized or is it a diffuse thyroid swelling? You can see it. There you go. It's a nicely bulged thyroid. It's a diffuse thyroid swelling. I'm performing a test or a method of examination. I'm using the thumb. I'm asking the patient to swallow. What is this called as? It is called as the �'Reil's method of thyroid examination. Now another one you can see here. Now this is one of my classical patients, a male patient with severely enlarged thyroid gland. You can see how big that is. Massive gland, right? He is unable to, even take the swallow. That's how the pressure symptoms are all represented. I want you to observe the gland. Look at that. Look at that. Look at that, right? The huge uniform thyroid swelling. It's a goitrous presentation. Okay. Now there is the sign that I would want you to see and comment on the box. What is this sign? What is the sign? You can see there's a blood vessel that is dancing. Like it's like a beat, no? Like a disco beat. It is dancing with this beat. If you want to check this out, right? It's that rhythmic factor that has been there. It's a dancing carotid sign, right? It's also called as the water hammer sign. It's seen in hyperdynamic statuses. In our case, in thyroid swelling, they're seen in thyrotoxicosis. Then there is a triangle to identify the recurrent laryngeal nerve. It is called as the Bayes triangle. It is formed by the following components. On the superior aspect, you have the inferior thyroid artery. Then you have the trachea on the medial end. And on the posterior aspect, this happens to be your common carotid. This happens to be your common carotid, right? Now, Bayes triangle is an anatomical landmark to identify this nerve. Can anybody tell me what nerve is this? This is your recurrent laryngeal, right? So this is to recognize your recurrent laryngeal nerve. You have the nerve that is passing through this Bayes triangle. Okay? Correct. Now, in the methods of examination, you have this thumb. Whenever you see, it is going to be your �'Reil's method. Now the �'Reil's method of thyroid examination is to watch out, or it is to look for the nodularity. It is to look for the nodularity of the thyroid gland. You have to see whether it is a nodular swelling or a smooth surface. It is for nodularity of thyroid swelling. It is to assess for the nodularity of the thyroid swelling, right? Then you have, this is what we call it as the Lahey's method. Now the Lahey's method is to palpate the thyroid gland in total. You will be using both the hands. With one hand you will shift. You can see I'm exerting pressure from this hand so that the swelling becomes prominent on the other side, and you will be able to palpate it. If you see one hand exerting the pressure, other hand the surface of the finger is used, the palm of the finger is used to palpate. This is your Lahey's method. Then you can see a patient putting both the hands, that is clasping the fingers behind the neck and then throwing the neck against it, against the resistance of the hand. This is what we call it as the Pizzilo's method. This is what we call it as the Pizzilo's method of thyroid examination, and the Pizzilo's method is done for the patient with short stout neck. Whenever a patient has a short neck or a compressed neck, to become more prominent or to make it more prominent, we will use Pizzilo's method, right? Now in the thyroid, this is asked, this is your Jawl's retractor. It's a self-retaining retractor used for thyroid surgeries. It's a self-retaining retractor used in thyroid, right? So this is the basis or the basic that I want to talk about the thyroid gland. Yep. So whoever is watching, is there anything specific that you want me to tell in a thyroid gland? You can just fire it away. Any concept, small thing, big thing, any why that you want to pitch. Any why, any why. No questions. Right. So these are small series that we are doing every Saturday. Uh, the objective is to give these small niche concepts. 1 hour is not enough, but I'll try to do repeated sessions like this on thyroid. We'll try to do one more time. There I'll be talking about few more important concepts of thyrotoxicosis, management, surgical components. So there are a lot of things that we can add on as we go across, right? If you have any questions, reach out to us on Instagram, on Telegram group, or on the PW's Medit channel itself. You can also do it on the app itself. Download the app on the Play Store as well as in your app stores that is present. It's MedEd is the app. So if you want to find out all the videos down there, you will find all the surgical videos in the MedEd app. So this is by our physics wala PW. It's called as the PW MedEd. You will find all the videos, surgical videos, you will feel all the clinical videos, everything is there. So feel free to reach out. Every week 1 hour will be live beta. Every week 1 hour we'll do a live session. You can ask n number of questions, anything. Vivian has a question: Riedl's versus anaplastic carcinoma. See, Vivian, Riedl's thyroiditis, it's a chronic inflammatory disorder. Anaplastic cancer is a malignant disorder. Unfortunately, the age of presentation, the sex of presentation, at the same time the pattern in which they present, they both are very similar. In fact, they are the most common differential diagnosis for each other. The only way you can differentiate is by performing biopsy. In Riedl's thyroiditis and anaplastic cancers, both of them are inoperable status. But in Riedl's, no. If I have a patient with severe pressure symptoms, I can do an hysterectomy, relieve it, and pressure the patient can live by. In anaplastic, it is associated with very poor prognosis because it will dissipate. At the same time, the average expectancy for a survival is only 6 months from the time of diagnosis. Otherwise, there is no clinical method in which I will be able to differentiate between anaplastic and Riedl's. What is the initial management for large pneumothorax in a hemodynamically stable patient? Okay. First of all, when you talk about pneumothorax, you need to understand, you're saying hemodynamically stable. Is it because of traumatic pneumothorax or is it because of ruptured bulla, right? If you have an X-ray in hand and you see the patient is stable, you don't need to put a needle. Directly go with chest tube. You're saying hemodynamically stable, known case of pneumothorax. I will go with chest tube, not with needle decompression. How to remember the TNM classification? I'll give you one of the examples of to remember the TNM classification. Okay. How to remember the TNM classification in the, I'll give you for the thyroid, then you'll understand the basic objective. Okay. Now imagine that this happens to be the surface, that is skin. Under the skin, what do you have? We have the subcutaneous fat. Let's say this is the subcutaneous fat that is present. And we all know under the subcutaneous fat, you have in the neck, I'm talking about, in the subcutaneous fat in the neck, you have a muscle that is going to be inseparable from the subcutaneous fat, and this muscle is what we call it as platysma, right? Under the platysma, what do you have? Under the platysma, you have the strap muscles. You take this as the representation of midline, and you see the strap muscles are present on the either side. You will notice that the strap muscles are present on the either side. Now below the strap muscles you have our thyroid gland. So this is the thyroid gland that is present. Behind the thyroid you have the trachea. This is the trachea. Behind the trachea you have the esophagus. This is the esophagus. And behind that you have the vertebra which is present across it. This is the vertebra. You will notice that the vertebra is lined by the prevertebral fascia. So this is your prevertebral fascia that is present, right? Thyroid gland will also be lined by your capsule. This is called as the pseudo capsule of the thyroid gland, and this pseudo capsule of the thyroid gland is formed by investing layer of the deep cervical fascia. Then you will notice that there is a nerve that is present in the groove. This is your recurrent laryngeal nerve. Now on the either side you will see there is this sheath that is present. We call it as the carotid sheath. In the carotid sheath, what are the structures you have? Number one, you have the common carotid vessel, which is the common carotid here. Number two, you have the internal jugular vein, which is here. It is the internal jugular vein. And behind this you have the vagus nerve. Behind this you have the vagus nerve that is present, right? So these are the structures which are present, right? So when you look at the whole component, this is your strap muscle that is present. Just for the sake of understanding, this is the strap muscles that you have, right? Now, just before we go, I'll just quickly label it. This is the skin. Under that you have the subcutaneous fat. Under the subcutaneous fat you have platysma. It's a subcutaneous muscle. This is your strap muscle. This is your trachea. This happens to be esophagus, and then you have the vertebra, right? So this is your common carotid. This is your internal jugular vein. This happens to be vagus. Now you asked, sir, how to remember the TNM, right? Now, any size which is less than 2 centimeters limited to thyroid gland, right? Any size of the tumor, which is less than 2 centimeters limited to thyroid gland, it is T1. Any size which is 2 to 4 centimeters, any size between 2 to 4 centimeters limited to thyroid gland, it is T2, right? Any size which is greater than 4 centimeters but limited, if it is greater than 4 centimeters but limited to thyroid gland, this is your T3A. As simple as that, right? Now any size of the thyroid gland or the thyroid tumor which is invading the capsule and involving the strap muscles, it is your T3B. As simple as that. Now how do you remember T4A and T4B? T4A, everything in the center, right? For example, you start from here. I'll use a different color so that we'll be able to justify it. Now if a tumor is starting from here, right, if it is going all the way to the subcutaneous fat, or it is going to the trachea, or it is involving the recurrent laryngeal nerve or the esophagus, right, or the esophagus, this is what we call it as T4A. On the other hand, if you go on the lateral side, if the tumor is involving or it is present here, if it goes involve the common carotid, mediastinal vessels or the prevertebral fascia, it will become T4. As simple as that. So when you start analyzing the TNM, no, as a surgeon, you'll start visualizing the tumors. As you start visualizing the tumors, no, you will start to understand that it is not difficult. It is how it is presented, and it will tell you whether you'll be able to operate or not. Okay, so this is one of the easiest way or the tricks to remember the TNM. Visualize them, right? Understand why are we staging them. We are telling, when I say T4, that means it is advanced. Why it is advanced? Because of the local infiltration. What are the structures it is involving? Will I be able to operate? If I able to operate, will I be able to salvage that structure? Will I cause more damage or less damage? For example, T4B, involvement of common carotid. I attempt with surgery, I damage the common carotid. The problem is the patient can die on table. Would you like to take that risk? Who the hell are you to decide for the patient, right? So you should be extremely careful, and that is what TNM teaches you. Yeah. Every Saturday, beta. Every Saturday. Beta, schedule is posted on my Instagram. I'll repost it today. Every Saturday, there's a list of topics that we're going to do. You can also suggest the topics, fire it away, put it on the group. We'll be there. See, slowly we're building the community, slow and slow. See, my objective here is purely to, educate students. Those questions, which you feel that you cannot ask in a class, those questions which you feel might sound silly, do a DM to me, right? Send it on the Instagram. Just tag me, or just put, if you don't want, you don't want your peers to judge you. I know it's all student, the doubts that you have. Directly DM it to me. Just send that question. Trust me, I will present that question or a doubt in the most presentable way that you will feel good about asking a doubt. Okay, so let's do it together, right? I'll always be there no matter what the question is, what the topic is. You can DM it to me. I will explain it on this platform, so it is available for everybody. It is not restricted by one particular platform. So I hope you all have a very well informative sessions moving forward, right? So thank you guys. Signing off from my end. If any questions are there, please do ping it up. Difference between colloid goiter and multinodular goiter, both are irreversible. Yeah, colloid goiters and multinodular goiters both are irreversible. Colloid goiter indicates a goiter which is becoming dormant, right? And multinodular will have a fibrous component. Both of them are irreversible. Yeah. So all the best, guys. Do well for your exams. At the same time, do well in life as well, right? So these sessions are not only going to be informative for exam, but also while you practice, right? So with that, signing off. Thank you.